This is for general information only, not professional medical advice. Always seek your advice from your physician. And of course, non-affiliation disclaimer. This is a cartoon of the bronchial tree, trachea, right main, left main, and there are many pulmonary segments, upper lobe, middle lobe, lower lobe, left upper lobe, lingular, and the lower lobes. All right. So if you look at it from the front, these segments are positioned at different areas of the lung and are drained by various bronchi into the main airways and up. So you need to position yourself at the correct place so that you will be able to drain the segment. Like this is posterior at the back. So you have to lie prone to drain a certain angle. What is the recommended duration for each postural drainage position? 5 minutes, 10 minutes, 15 minutes, 20 minutes, or 25 minutes? What is the recommended duration for each postural drainage position? So 10 minutes, yes, good. At least 10 minutes, better 15 minutes, so that the secretions will drain properly. Because it's actually quite far. Let's say if you have something in the posterior part, posterior basal segment of the right lower lobe, then it takes some time to come up. How often should postural drainage be performed? Once a day, twice a day, more than twice a day when it's more mucus. Yeah, correct. Once a day, probably not enough. Twice a day is good. But when there's an exacerbation, more mucus production, then obviously, you can do it 2, 3 times, 4 times a day. So how do I decide on the best position to perform postural drainage? Choose the position I feel most comfortable. Choose the position which I feel produces the cough. Ask Google. Confirm after a chest X-ray. Confirm after a CT scan. Confirm after a high-resolution CT scan. So choose the position I feel most comfortable is not correct. This is important. Position which I feel produces the cough. Usually, the position that produces the cough will ask the person actually to sleep in that particular position or lie in that particular position, simply because that is how drainage is being affected. Because of that particular position and it is draining that particular segment of the lung, you find that the person actually produces the cough. So we will tell them, patients especially with bronchiectasis, to sleep in the position where there is most cough. Once the secretions are all drained out, the cough will decrease. As regard to imaging, chest X-ray cannot. PA view will not show whether it is on the medial segment or the lateral segment. So definitely chest X-ray is not correct. CT scan, not as good. You need a high resolution CT, right? The word is high resolution CT. That means many cuts, many more cuts than the ordinary CT scan. Now, why is there so much mucus? All of us will produce mucus. More becomes sputum and phlegm. So the mucus, why is it being produced more? Because irritation, inflammation, irritation. These droplet cells produce more mucus. And normally our cilia present in the airway, in the mucosa, will sort of like sweep the mucus upwards to be swallowed. Normally, all of us will produce mucus, but it is in such small amount that we don't notice, and we usually swallow it. So when there's excessive production of mucus, there will be cough, then you can spit out, the sputum and then the phlegm, that kind of thing. So why is the presence of cilia important? Because in the absence, like in ciliary dyskinesia, then you have abnormally functioned cilia, then the drainage of this mucus will not be proper and adequate. So here is a video showing what happens when one has good ciliary function, known as a ciliary escalator, and also when there is improper cilia function. Notice the cilia are moving in one particular direction. Actually, cilia. That's why the mucus will move in one particular direction. Not. Okay, so what happens in bronchiectasis? So bronchiectasis is the main problem for people who produce a lot of mucus. Of course, there is chronic bronchitis, acute bronchitis also produce a lot of this mucus, phlegm and sputum. But in bronchiectasis, we pay particular attention because this is where the postural drainage technique is most important. So it is a normal airway. There are 3 components to bronchiectasis. One, lactation. of the airways is inflammation, excessive production of mucus, of course, dysfunctional ciliary function. So altogether, there will be mucus retention, abnormal mucus retention, and also abnormal production of mucus. So you can see on the right-hand side, this is a dilated airway. The wall is thickened. This is the pulmonary artery, all right? So when the airway is bigger than the artery, it is abnormal. When it's 1.5 times bigger, it's definitely bronchiectatic. And in bronchiectasis, there's tram line. You see tram lines, right? It's like the train flowing across, running across. This is like parallel railway tracks. That's why I call it tram line. And all this will go towards the periphery. Normally, you will see these airways, normal airways will taper towards the periphery. Oops, will taper towards the periphery. Whereas in bronchiectasis, the airways are tram-like, parallel, and goes towards the periphery because they are dilated. Normally, you don't see them at least 1 cm from the pleura. Here, you probably can see them more. And of course, infection sets in because of the abundance of mucus. And when germs get in there, they will grow. So we get consolidation, patterns of consolidation, you can see here. Okay, so airway clearance is important. Now, why do we use mucolytics? Is there any medicine that reduces the production of phlegm? Do you know of any medicine that reduces the production of phlegm? Hardly any. What it does is, these mucolytics is actually to make the mucus more liquefy them so that it are easy to come out when you do the postural drainage techniques. For airway clearance, you can add on mucolytics, especially when the mucus is very thick, very sticky, very difficult to expel. Now, this is very important. Active cycle of breathing technique, ACBT, the word is ACBT, active cycle of breathing technique. It comprises of several modes of breathing. First of all, the relaxed breathing, known as diaphragmatic breathing, slow, relaxed breathing. And then you have the huffing to bring up the phlegm, to mobilize the phlegm towards upwards, so that you can have a controlled cough. So these techniques we will teach in the next session: diaphragmatic breathing, huffing, and controlled breathing. The postural drainage techniques we have seen already. So in the Tan Tock Seng video, you can see how the patients are being placed, various degrees, right side, left side, certain angles, prone, supine. So positioning is very important. And you decide on this positioning after reviewing the HRCT thorax. So the HRCT thorax is very important for this diagnosis because right now we do not do any more air bronchograms. We do HRCT to diagnose bronchiectasis. So with that diagnosis, we will want to know which part of the lung is affected, which areas are affected, is it single, multiple, and which portion. If you can go down to the pulmonary segment, that would be the best. Because if you know the pulmonary segment, you exactly know how to position yourself. There are various diagrams, but the Tan Tock Seng video is pretty good. You can actually follow that video. So while lying down, allowing the gravity to drain the secretions. So better if the secretion is more liquid, right? It will drain faster. If it's thick, slower. Added on, there will be manual techniques. What are the manual techniques? There will be percussion. We will demonstrate percussion the next time when we come. Percussion, vibration, vibrate the chest. The techniques, I think it is shown in the video, how to vibrate the chest, and also compression techniques. So percussion, vibration, and compression. During the expiratory phase, secretion is mobilized, and you do the huffing to bring the secretion up towards the trachea. And when one feels the secretions is at the trachea level, high up here, then you do the control cough. All right, so there are various techniques, to get the phlegm out. So that is the way it should go. So you loosen up the flanks, which are sticking at the airways by percussion, vibration, compression. It do several times in cycles, and then as they come upwards, also with the huffing, if you feel it at the throat level, then you do the control cough. Control cough, there's a word to that. Now, to assist that, some people have difficulty getting a partner to do the chest physio or a trained physiotherapist to do the chest physio for him or her. One can rely on oscillating PEP devices, all right, or vibratory PEP devices, positive expiratory pressure devices. These are better than the plain positive expiratory pressure devices, the PEP devices, because added on to this device, PEP device, oscillation. When one breathes out through the device, there's this vibrator inside the device that helps loosen up the fan in the airways. So that will be equivalent to the percussion, the vibration, and the compression. So this is very handy. This kind of equipment very handy for people who are ambulant, young people who are moving around, doing jobs at different places, different countries, etc. So they are self-reliant, but one has to be persistent. That means continuously do it, maybe twice a day, in the office, not to be shameful about it. That we can do it in the office while even sitting down at the desk, we can do that. So it's important. Now, the other equipment is the high frequency chest wall oscillation, HFCWO. So this one is a vest put on the person, let's say with bronchitis, and the physiotherapist can adjust the frequency, how fast the oscillation is, and the pressure to be transmitted into the chest wall, into the lungs. And that will sort of shake up the situations and followed up by ACPT. So it has to be followed by ACPT. So the technique of ACPT is very important. Very important. And this ACP technique can be practiced by all of us actually, when we are having a cough, bad cough, a lot of phlegm, you can practice ACPT to bring out the phlegm. Right? So this kind of techniques are immediately useful to people, even without bronchitis, normal people. You have the chesty cough, you can just do ACPT. Another method will be mechanical insufflation, exsufflation. Issues. Cough exists will be equipment whereby when there's a lot of phlegm, and this equipment is used for people who have very weak cough, they may be having post-stroke. So what does this machine do? It is put into the mouth. The machine produces positive pressure, pump air into the airways. After several pumps, insufflation into the lungs, it will extract, sufflate, and then it will suck out the phlegm. Yeah, this is a very good one for people with, let's say, who have neurological weakness, myasthenia, chest wall weakness, chest muscle weakness, etc. And then you have another technique which is called the intrapulmonary percussive ventilation. This, of course, is used together with the ventilators. It is actually pretty good. You can adjust the frequency, the pressure, and then the inspiratory expiratory ratio. So, any questions?
Hi, doctor.
Yeah.
Yeah, I have a question. So why we cannot perform postural drainage for a patient with hemoptysis?
Okay, yeah. Hemoptysis, depending whether the hemoptysis is fresh or stale. Especially if it is a lot of blood, massive hemoptysis, or even moderate hemoptysis, be very careful. You can do breathing techniques, and then, but definitely percussion would be a little bit difficult in the sense that, the patient would be very alarmed if you do on the person, coughing out blood. Secondly, is that if there is excessive coughing, the bleeding we start again in the sense that because in bronchitis, usually it's bronchial arterial bleeding, you see, or inflammation. So how it stops bleeding is because of the clot. The bleeder has to have a clot over the site of bleeding to stop. So excessive coughing, the clot is not well formed, not solidified, it can be coughed out. So once it's coughed out, it will bleed again. So that's the main reason. All right, but still hemoptysis continue, and of course, while hemoptysis, if you feel that there's one will benefit from the chest physio, one will continue. But if we will write down there, gentle chest physio, gentle chest physio. That means no heavy percussion, maybe just some vibration, very gentle vibration and compression to bring out the phlegm. All right, so we have to clear the secretion, otherwise the infection cannot clear. So why bronchiectasis? The infection is difficult to clear because the bacteria are at the are actually residing in the mucus, you see. So when you eat antibiotics or when antibiotics are given IV, the antibiotic has to diffuse across the mucosal wall and to reach sufficient concentration in the mucus to kill the bacteria. You know what I mean? So that's why it's very important, even though there is a bleeding, but be very careful of the technique of postural drainage. You still need to get rid of the phlegm. Otherwise, the antibiotics cannot reach the germs, right? If there's a lot of phlegm or thick and all, and then of course clogging of the airways, there will be oxygen desaturation. Okay, does that answer your question?
Yeah, okay. Thank you, doctor.
Yeah, any more questions?
Doctor, one question here.
Yes.
Let's say after percussion, I spit out only, I managed to spit out only next day. Is it okay or not? But it's not a lot lah.
So this is a good question. Now, if a person has bronchiectasis, we always tell everyone to do at least once a day the postural drainage and the chest physio, if not twice a day. So when the airways are pretty clear, all right, that means to say very well drained, because one has been very obedient to the advisor that to do it regularly. Then because as the mucus is being produced, it is sort of removed by the physiotherapy techniques, then there's not much left. So when doing, and even after doing, you may not even have phlegm or cough, you see, but one must continuing doing the chest physio. Why? Why must we do that? Why must we do that? So usually, when patients ask, I got no phlegm, no cough, why should I continue to do chest physio? Anybody knows the answer? Why must one continue to do chest physio if one has bronchiectasis, even if there is no cough and no phlegm produced?
Is it because to maintain our what you call that condition, so that the phlegm won't build out and won't accumulate? Is it because of that?
Okay, so the phlegm produced is very little when it is well drained, all right? So it's so little, and commonly the bronchiectasis occurs, commonly, not always, at the bases of the lung, all right? So when it's so little, when the person is doing chest physio every day, even diligently twice a day, then after the session, one can have the cough coming out maybe several hours later. Because you see, even when a person has bronchiectasis, not all the airways are affected. So what happens is that the area that has phlegm, now the phlegm is shifted onto the airways with the normal cilia. Okay, the airways with the normal cilia. So that will gradually escalate the mucus up and to be swallowed. So sometimes, very often, in fact, the people who have been doing very well say that nothing come out during the physio session, but 3-4 hours later, we just swallow it. That is actually a good sign that they swallow the phlegm several hours later. That means it's so well drained that is so little phlegm left in the airways. Does that answer your question? So meaning to say you can do the physio, nothing happens. Several hours later, maybe a spittle, a small spittle.
Doctor, phlegm, we're trying not to swallow, right?
You can
Isn't
swallow.
it, phlegm is made of bacteria and all that. So it's not so advisable to swallow it, right? We try to speed it up.
Obviously, if you can spit it out, that's the best. Yeah, but sometimes it's so little, it's like us swallowing the normal mucus, you see. You know what I mean? So it's actually quite harmless swallowing the mucus if it's very little, or the phlegm which is very little, because your stomach will actually digest the bacteria and kill the bacteria because of the acidity.
So if it's a green color, I mean, continuously green, that means our body is fighting with with some infection, is it? The color of the mucus.
Yeah. So you must come for the talk by the students on the 8th of June. There's a talk coming on 8th of June, Ipoh Lung Health Day. They will be explaining all the colors of various sputum. What are the colors, how they become colored. Please come and attend the talk. Generally speaking, if it is colored, usually there is a infection. Of course, in asthma, sometimes it can be green, but because of the high number of eosinophils, but usually we will associate colored sputums with infection. Usually,
Dr. Leong,
Yes.
if you need more than 10 to 15 minutes to do the postural drainage, so is it harmful? You have to take sometimes about 30 minutes like that before you can really come out the phlegm.
Yes, you can go as long as you wish, as long as you're comfortable, not having breathlessness. You know what I mean? You can sleep and then maybe listen to the music and then continue. You don't have to be continuous. You can let it be. Let's say you want it 20 minutes. You can actually do it 20 minutes. You can actually break it. You don't let it rest, breathe. That's why the ACBT, there's this relaxed breathing that actually helps to push the phlegm up slowly. Oh, it's okay. As long as you're comfortable and not being breathless while doing it.
Oh, okay, thank you.
Doctor,
Yes.
hello.
Yeah.
I'm Liu from your previous internal medicine group. I want to ask regarding, because just now I didn't catch the lung segment part. I want to ask which lung segment are commonly affected in bronchiectasis and what are the corresponding positions for the drainage?
Okay, usually the lower parts of the lungs, usually the basal, very often the basal, because the basal are also more prone to atelectasis, especially in the elderly. Atelectasis of the lung is pretty common, especially if you do a lot of CT scans and you see a lot of CT scans, atelectasis is pretty common. So what happens is the atelectasis is collapse. Why collapse? Because of poor breathing, not deep enough breathing, and also because of infection, commonly at the bases. All right, and also sometimes because of aspiration, micro aspiration. Elderly have micro aspiration, small amounts of aspiration, especially during sleep. So that's what happens. So bronchitis is more common in the bases. It could be the right or left basal segments.
Oh, okay. Thank you, doctor. Doctor, another question. What does current evidence say about the efficacy of postural drainage compared to modern airway clearance device? What does the current evidence say about the efficacy of postural drainage compared to the modern airway clearance devices like your PEP and HFCWO?
Oh, okay. They are equally effective actually. But of course, if there's a cost involved for buying the equipment, that's one thing. And the best is actually to do things that, it doesn't need machines, that is a simple, before the machines were invented, they were all doing this postural drainage. But the auxiliary PEP or the pre-PEP devices are pretty good. We always recommend, and especially for people who are ambulant, young people who are having it. Yeah. Yeah, but even then, having said that, if there is a bad infection, even if they have the pre-PEP device, we will add on physical techniques like postural drainage, real postural drainage to drain. Because you see, if you are using the auxiliary PEP devices, most of the time we are sitting down. We blow the thing, the vibrate, and so the drainage may not be so efficient. Whereas if you let's say the bases, posterior basal, all right, then if you apply prone, percussion, vibration, which is actually the vibratory pad is doing, but now we have gravity added on, you see. So definitely it will be a better technique to employ. Also, during bad infection, lots of them we will advise together come in. So continue with the PET device at home, come in for chest physio in the hospital maybe once a day until the infection is cleared.
Oh, okay. Thank you, doctor.
So what's the beautiful sign in the hand that you can see with bronchiectasis? Not always there, but what is it? The hand signs that signifies the patient may have bronchiectasis. What should you be looking for?
Clubbing.
Very good clubbing. You see clubbing together with this. Yeah, beautiful clubbing. Not always there. I've not seen one, unless it's very bad. Cystic bronchitis are very bad. Yeah. Bronchitis is pretty common, Yeah. Any more questions? Okay, one last question anymore. We're close already because, yeah.